The human vertebral column consists of 33 individual segments, stacked vertically to form the central mechanical axis of the body. Under extreme physical load, it operates as a highly kinetic spring, bending and rotating to facilitate bipedal movement. This demand for mobility exists in direct opposition to its secondary mandate. The vertebral column must simultaneously serve as a rigid, bony vault to protect the fragile nervous tissue of the spinal cord. This dual requirement for movement and defense creates a permanent structural tension. The design flaws born from this compromise dictate the precise mechanics of clinical pathologies, ranging from congenital neural tube defects to debilitating radicular pain. To accurately diagnose how the spine fails, we must first isolate the distinct microscopic and macroscopic weak points engineered into its architecture. In a clinical setting, structural integrity is initially evaluated using two-dimensional in vivo imaging. This is a standard antero-posterior radiograph of the cervical and upper thoracic region. Down the center, dense, stacked blocks of bone form the vertebral bodies, bearing the majority of axial weight. Projecting laterally are transverse processes, acting as leverage points for muscles. Interpreting trauma on a flat projection like this requires a complete three-dimensional mental model of the typical vertebral unit. We can understand the spine's division of labor by isolating a single typical vertebra. The structure is divided into two functional zones. The anterior functional zone is the vertebral body. Shaped like a short, thick cylinder, it is engineered entirely for structural solidity to support and transfer axial weight down the chain. The posterior functional zone is the vertebral arch. This arch is constructed from paired pedicles extending laterally from the body, connecting to paired laminae that meet at the posterior midline. The union of the solid anterior body and the posterior arch creates the vertebral foramen. This anatomy splits the physical burden. The body absorbs the physical load, freeing the hollow arch to act purely as a protective vault for the spinal cord. This protective vault is not fully formed at inception. During embryonic development, the posterior arch grows as two separate halves that must migrate and fuse perfectly. The precise junction where the two laminae meet at the back of the spine is a highly vulnerable developmental checkpoint. When the neural folds fail to close properly, it results in a developmental anomaly known as spina bifida. In its mildest form, spina bifida occulta, the vertebral arch simply fails to fuse. The bony defect exists, but the skin remains intact over the gap, and the neural tissue remains inside the canal. In a severe manifestation like meningomyelocele, both the spinal cord and its protective meninges protrude entirely through the unfused arch, exposing the fragile neural tissue outside the spinal column. Because this tissue lacks its bony shield, infants with severe forms of spina bifida typically require cesarean delivery to prevent the narrow birth canal from crushing the exposed spinal cord. A millimeter gap in fetal bone formation nullifies the spine's ability to protect the central nervous system. When vertebrae are stacked, their interaction introduces a new mechanical stress point. Superior and inferior articular processes project from the junction of the pedicles and laminae. These interlock with adjacent vertebrae to form synovial joints, allowing the spine to twist and bend. Located exactly between these superior and inferior facets is a narrow bridge of bone called the pars interarticularis. This specific narrow bridge must absorb massive mechanical shear forces during extreme flexion or under heavy lifting. If this bony bridge fractures under traumatic stress or fails to develop properly, the interlocking mechanism breaks down. This condition is called spondylolisthesis. Without the articular processes holding the column in alignment, the affected vertebra displaces forward over the one below it. This slippage most commonly occurs with the fifth lumbar vertebra sliding straight over the body of the sacrum. The synovial joints that grant the spine its mobility are the exact same structures that leave it vulnerable to traumatic shear failure. The vertebral bodies do not rest directly on top of one another. Cartilaginous joints separate them, accounting for a full 25. The annulus fibrosus binds the vertebrae together while tightly retaining the high-pressure nucleus pulposus inside. The spine's ability to act as a dynamic shock absorber relies entirely on the tensile strength of that fibrous outer ring. But the annulus fibrosus has an asymmetrical weakness. Its posterolateral edges are thinner and lack the robust reinforcement of the posterior longitudinal ligament. Under severe compression, the nucleus pulposus can rupture through this posterolateral weak point, protruding out of the disc space and encroaching into the vertebral canal. To understand the resulting pain, look at the precise spatial geometry of the lower lumbar spine. Lumbar nerve roots do not exit horizontally, they descend obliquely within the subarachnoid space. The L4 nerve exits through its foramen, but the L5 nerve root continues to descend past the disc space between L4 and L5. When a disc herniates posterolaterally at the L4-L5 level, it creates a highly predictable collision. The herniation typically misses the L4 nerve root that has already exited above it. Instead, it compresses the descending L5 root on its way down. This specific nerve impingement causes sciatica, projecting pain and numbness straight down the lower limb. Radiculopathy is not a generalized pain response, but a highly predictable consequence of geometric mapping and fluid dynamics. Zooming out from individual nerve roots and facets, the aggregate alignment of these 33 segments determines human posture. The column naturally rests in an S shape. The thoracic and sacral regions contain primary curvatures that develop early in the embryonic and fetal periods. The cervical and lumbar regions contain secondary curvatures. These form only after birth, developing as an infant builds the strength to hold up its head and eventually walk. Over time, variations in bone density and muscle tension alter the physics of these curves, creating distinct macropathologies. Osteoporosis can erode the anterior vertebral bodies in the upper back. This causes kyphosis, an abnormally exaggerated thoracic curvature. Alternatively, weakness in the trunk musculature can fail to support the lower back, resulting in lordosis, an abnormally increased lumbar curvature that shifts the pelvic angle. An adult's physical posture is simply a temporary state of equilibrium, balanced between infant developmental milestones and the cumulative effects of gravity of age. The human spine functions as an engineering compromise, balancing load-bearing rigidity with the protection required for the nervous system. When healthy, this column of joints, ligaments, and bone transfers kinetic energy from the ground up, driving explosive bipedal motion. But its failures are never random. From a microscopic lack of fusion in the neural arch to the violent shear of a fractured pars interarticularis, spinal pathology follows strict mechanical rules. Predicting exactly how and where the architecture will break requires an understanding of how individual facets and processes interact under load.